All right, Gail, I'd like to call.
All right, we'll give it just one more minute, give people a chance to log on electronically, and then we'll go ahead and call the order at 10:32. So let's give it one more minute here. All right, we will go ahead and call the order at 10:32. Just a couple of housekeeping items before roll call. A reminder, this meeting is being recorded. Anything shared or said on the meeting will be part of the recording, which is posted to our website. Also a reminder, if you are not speaking, if you could please put your phone or computer on mute so we do not have the background noise. If you're joining by telephone only, you will need to press *6 to unmute yourself. Otherwise, if you are on the virtual platform, you can go ahead and just use the mute button to mute or unmute yourself as well. We will go ahead and start muting people that are not muted on your phone here in just a minute. And then if you needed to unmute again, *6 is how to do that. Thank you for everyone for being flexible with this virtual only format, and I'll turn it over to Shelley for roll call. Thank you.
Good morning, everyone. Alberto Gutierrez, Bob Ramsey, Brian Smith.
Present.
Chris Salvino. Dale Woolrich.
This is Dale. Dale is present.
Oh, thank you. Dan Spate.
I'm here.
Deb Grande.
Present.
Franco Castromarin. Gail Bradley.
Present.
Gareth Gamer.
Present.
Glenn Kasperzer.
Present.
Heather Miller. Howard Reed. Oh, okay.
Heather Miller's here. Sorry about that.
Thank you. Howard Reed.
Present.
Eve Gostenker. I saw him.
Present.
James Hayden.
Present.
Michelle Preston.
Present on phone.
Mike Devan. Neil Williamson. Rebecca Harrow.
I'm present.
All right, I've got Rebecca Rodney Reed.
Present.
Roy Riles,
Riles, and I'm here.
sorry. Sarah Crody. Carrie Brand.
Present.
Sharon McDonough. Stevie Merrill.
Sharon McDonough is here.
Oh, thank you. We still have Stevie still on? Yeah.
Oh yeah, present. Can you hear me? Present.
Thank you.
Yeah, Stevie's here. She's on the phone.
All right.
Sorry
thank
about
you.
that. Here I am.
Todd Jaramillo.
Present.
Vince Martinez.
Present.
Vivian Gillert. We have quorum. Thank you.
All right, thank you very much, Shelley. In your packet, there is an attendance report. Just a reminder that if you missed 2 or more consecutive meetings, the Bureau will reach out to you to inquire if you would still like to participate in the committee. We currently have 3 vacancies. These are on your agenda packet as well. 2 public members and 1 for hospital administrator for a county population of greater than 500,000. I just wanted to mention a couple standing items in regards to the Naloxone Leave Behind program. The Bureau is really trying to spread the message regarding increasing access to naloxone to address the opioid epidemic. Throughout COVID, we have seen an increase in the numbers of opioid overdoses, and we see EMS as really being well suited to help provide naloxone to the community. If you go to our Bureau website, which Shelley has pulled up here, one of the main squares that you can select is specifically for naloxone. We have the standing order for EMS providers if you're a BLS-only agency, a letter regarding naloxone leave behind, as well as a sample training that you can make for your jurisdiction. We've also put together a template educational pamphlet which can go out with the naloxone itself. We have a link as well, which you can see there under Order Naloxone. You can order naloxone for free from the Office of Injury Prevention as part of ADHS as an EMS agency, and they can make this available for you to distribute within your community. So again, we just wanted to re-emphasize and keep bringing this up at meetings as a way that we can help spread the message regarding the Naloxone Leave Behind program. Next on the agenda is just a reminder that the National Association of EMS Officials, NASEMSO, is finalizing their update to the Model EMS Clinical Guidelines. This is going to be the third version. There's a public comment survey which is linked in your agenda. This will be closing shortly, and they are looking to finalize and get these published within the next few months, hopefully. These were the basis for our updates to the last TTTGs, as well as the initial version that we did here within Arizona. And so we will look, once those are updated, to start that process again with updating our statewide TTTGs. Next, I will hand it over to Chief Garcia for the Bureau reports. Chief Garcia.
All right. Good morning, Dr. Bradley and council members. I just have a few updates to share. We know that back in August 2021, Arizona EMCT scope of practice and drug tables were updated based on national standards and recommendations from the Medical Direction Commission, and that included considerations for EMCTs working in hospital settings. Today, MDC will review EMCT scope of practice again and provide recommendations to the department. This process may require exempt rulemaking, and we'll keep stakeholders updated on MDC recommendations, next steps, and timeline. For now, guidance on EMCTs working in hospital settings is outlined in a substantive policy statement from the department, which includes scope and other requirements. We do not have any updates on air or ground ambulance rules at this time. However, the Article 9 work group will convene again in February to provide additional feedback on CON rules, including recommendations on response times. Regarding some of the recent trends we're observing with the Omicron surge, we continue to see a high volume of positive COVID-19 cases. Although hospitalizations are not increasing at the same rate as Omicron cases, we know that EDs are saturated and the number of staffed beds in hospitals remains extremely limited. We do recognize that some facilities have activated crisis standards of care based on staffing levels. And as we navigate some of these ongoing challenges across the healthcare and EMS system, the Bureau would like to lean on statutory committees like the EMS Council to help provide recommendations on guidance on strategies for EMS surge that can be applied statewide. So we really are going to lean into the council, and we would like to hear from you if you have any recommendations or guidance moving forward. We're working on pulling together a group of stakeholders to discuss strategies on EMS surge, including ground and air transport agency coordination on long distance transports, which we have seen increase significantly in the last couple of years. A little bit later in this agenda, we would like to also focus on some bright spots and highlight some best practices that we are seeing in the state. We're especially impressed by the collaborative and data-driven approach of the Southern region to improve EMS and hospital transfer of care. Thank you to some of the folks that will join us a little bit later. Here in the Bureau, we are committed to providing timely updates to EMS and trauma providers through our regional council contacts, as well as our Gov Delivery listserv. If you have not done so already, please subscribe to the Gov Delivery updates from the Bureau of EMS and Trauma System. Again, Gov Delivery will remain one of our primary methods of communication at this time. Next on the agenda, we would like to make sure that we are welcoming our new Bureau staff. We've been quite busy with recruitment and hiring. Antonia Gerard joins us as our new rate analyst with the CON and rates program. We also have TJ McKay, who is our new training program manager with the Bureau, and Cody Curl, EMS Workforce Initiatives Coordinator, working on a new grant and quite a few projects across the Bureau. So thank you to our new staff. We look forward to working with you and introducing you to the council and our statutory committees. I will pass it back to Dr. Bradley for the next items on the agenda.
Thank you for that update. I'm going to just very briefly touch on opioid and out-of-hospital cardiac arrest data trends. We have been providing this data update at each of the meetings for the last year. Vatsal and her team look at that regularly. It does appear that we still are seeing increasing numbers and trends with both of those entities, but we needed to do a little bit deeper data dive before we shared that data at today's meeting. So we look forward to bringing that back to this committee in May. Next for the update is the SHARE program. I just wanted to mention that one of the things we have been really trying to do is to reinvigorate and reorganize the SHARE program. And for many of you who were around when Dr. Bravo first started SHARE, we're at almost 15 years since Arizona kind of initiated this program. And one of the things we have done in the last 6 months is to request that all cardiac receiving and referral centers submit their documentation to ensure that they meet the capabilities to be either a cardiac receiving or referral center. We feel that that is really important for EMS. If we're going to ask EMS providers to potentially bypass one facility to go to a cardiac receiving center, we want to ensure that they still have the capabilities that they attested to having 15 years ago. Moving forward, we look to having that process being a regular update in a 3-year cycle to ensure that we maintain visibility on the program itself. We are also looking long-term with our informatics team here within ADHS to really attempt to find a way to try to automate the data. This will not be a quick process, but we recognize the hospitals that this data input is work hour intense, and so we really want to find a way to make this easier. So that is going to be one of our long-term goals. Really when I go to national meetings, what's highlighted over and over is that Arizona is really one of the leaders in out-of-hospital cardiac arrest resuscitation, and it's based on the SHARE program. The collaboration that was developed between EMS and hospitals, starting from bystander recognition of out-of-hospital cardiac arrest, dispatch-aided CPR, and then through the continuing to the ICU care in the hospital. That significantly increased survival from out-of-hospital arrest, and that data has been published both nationally and internationally. So really, we want to make sure that we highlight this program, work in finding ways to reinvigorate it, and just help increase the survival for out-of-hospital cardiac arrest patients. So that is my statement on the SHARE program and just the why, in case you've gotten questions from your hospital, if you work at a hospital, as to why the documents were requested, the rationale behind that. Next, I'm going to turn it over to Anne, who's going to just touch briefly on an update regarding our Premier EMS Agency Program data quality standards. As many of you remembered, we went through an update on the data quality standards, I think for almost a 2 to 3 year cycle as to what standard we were going to use. I see some of you smiling on your cameras. So we did finally adopt a standard that was approved by EMS Council last year. And so I want to turn it over to Anne if we can open her presentation, and she will just give you kind of a state of the state as to where we are currently.
Good morning, everybody. Shelley, I'm going to present unless you want to pull up the presentation, whichever way is fine.
I just stopped presenting.
Okay, great. Let's see if I can get this right the first time. Okay. Can everyone see the slide, hopefully?
Yes, if you can make it a little bit bigger, be more readable.
Oops. Is that better?
Do you want to go ahead and start your slideshow?
Oh, it didn't. Isn't it showing?
So it may be using the slideshow view. So if you go to near the bottom right and just use the little, what looks like a screen, that'll make the slides bigger.
Okay.
We lost your presentation there, Anne.
Okay. All right. Hopefully now.
And if you go to the very left side of the screen and hit from the beginning, it will make it bigger and get rid of the ones on the left-hand side.
Yeah, I did that. I don't know why it's not. I'll try again. Can you guys see just the slide on the screen? Otherwise, I can present my entire computer. I just usually don't do that, but if it's not showing it, I'll do that. I don't have anything up anyway.
It is showing, it's a little too large now. If you want to just maybe go down to, yeah.
Okay. Too big. I feel like Goldilocks. Is it just right? Now? Maybe?
Yes, I think that should work for now. And we can certainly make this available if anyone needs it after the meeting as well.
Sorry about that. It's ironic I'm having technical difficulties and I work with technology, but on my screen, it looks great. I'm so sorry. So as Gail mentioned, I'm sorry if I clear my voice occasionally. This is just a short update on the progress and status of the validation score for preparedness agency, the data completeness program that was approved by EMS Council and TEPI. So just a reminder, the AZ-Peers data set is part of the NEMSIS data set, but it's a much smaller portion than what NEMSIS has available. And the approved measures that are in place is a requirement for a median validation score of greater than or equal to a score of 90. So it's not a percent, it's a score. Agency score reports were to be provided at a minimum quarterly. We actually provide them on a monthly basis at the first of each month. So we're doing it more often. 1 year from go live. Sorry?
I'm sorry, Anne. We're still on the title slide. Are you advancing?
Okay, all right. I'm going to do my whole thing. I don't know why it's not working. And if it doesn't work after this, Shelly, I'll just have you pull it up because I just emailed it.
Okay.
But
yeah.
I'm doing my entire screen. It's just good practice, I know, but you can't see my slides advanced, and it's just, can you guys see the second slide now?
Yes, ma'am.
Yes.
Yay! I'm so excited. Okay, this is the part where I was saying about how AZ-Peers is a much smaller data set than the entire NEMSIS data set. Okay, so EMS Council approved several points to the quality measures. One was a median validation score of greater than equal to 90. Agency score reports at a minimum quarterly, but we've been providing them monthly. And 1 year from go live to bring the score up to the greater than or equal to 90 medium. So the go live date that was chosen, there was a January EMS Council meeting and the March TEPI meeting, was March 1st, 2021. So they have 1 year from that, which would be March 1st, 2022, to bring the premier EMS agencies to bring their scores up to 90 or above. So the first assessment is going to be in a little over a month. The qualifying score, once again, it's a median for that month, and it's either going to be the previous 1 month or an average of the last 3 month median. So if the agency can meet either one of those for a median score of 90 or above, then they meet the criteria. There will, of course, be a 3 month grace period, which we discussed before, for changes of an EPCR vendor or versioning changes, which are coming up this year. So the current status, it's good news. So 94% of the premier EMS agencies are at or above a score of 90 as of the 1st of this year. And as compared to a year ago on the 1st, only 84% of the premier EMS agencies were at or above 90. And so far, of the agencies who increased their score, because remember, quite a few were already at 100, so I didn't include those as far as increase because you can't get higher than 100. Of the ones that increased their score, they averaged a 10-point increase in the last year, which is great. And we have reached out to those agencies that are still scoring below 90 as of the 1st of this year. And I've heard back from several of them, and they're working on their scores to hopefully for this last month of measurement in February to bring them up above 90. And that's it for me. I think the presentation took less time than it did for me to actually get it viewable. Thank you.
Thank you, Anne. You know, it is really nice to see that we've seen an increase in some of those scores. If you can just, I was going to say, go back to the last slide, but that's okay. We won't go through that again. But, you know, we really have seen a nice increase in some of the agencies that were struggling. And so the fact that there are very few agencies that are currently below that 90 score cutoff. And again, Anne has worked really hard to kind of reach out to those agencies to help them meet the standards. So I think we are close. We just wanted to make sure we gave this team an update because the next time we meet, which will be May, at that point, anyone who has not met that data standard would have lost the Premier EMS Agency Program status. And so we wanted to make sure we had that discussion with the group since EMS Council is really vital in setting that data standard. Are there any questions at all regarding that? And again, if you or your agency are having any issues with your scores, please reach out to Anne. She is a wealth of resource. She's really built our data system for AZ peers in Arizona and really is viewed nationally based on people I met at a national conference. She is a national expert on the subject, so please feel free to reach out to her. Next, I'm going to turn it over to Travis for EMCT certification and educational resources. Travis?
Thanks, Dr. Bradley. Can everyone hear me okay? Can everyone hear me?
Yes, we can.
Okay, great. So good afternoon, everybody. So in regards to the EMCT certification, as some of you may already be aware from previous committee meetings, over the next few years, the Bureau will be heavily focusing on IT improvements related to the EMS portal to provide additional value to our stakeholders, end users, and internal staff. These improvements will consist of modernization efforts to improve the look and feel of the portal, allow the end user to access and submit various applications from any smartphone, tablet, or web browser, develop a hub where the Bureau announcements, education, training materials, CE courses, and wellness resources will be located. We also will be creating a fully online CON application to eliminate the need to submit paper applications and develop a user-friendly online race application and much more. The Bureau's vision for the EMS portal is to create a one-stop shop for all tasks, duties, and applications that relate to the EMS and trauma system. For our internal users, the improved EMS portal will provide real-time data and reports at the click of a button, have a customizable dashboard that displays important program metrics and processing timeframes that can be tailored to a specific user, and much more. The improved portal will allow our team to be more agile, efficient, organized, and productive, which will have a wide-ranging positive impact on our community. The portal will be a place where stakeholders and internal and external users will want to access often due to the value it can provide in our everyday work lives and personal lives. Our first focus will be on improving the EMCT certification process. I'm pleased to report that since the project kicked off a few months ago, much progress has been made to the EMCT certification process for external users. At this moment, we're currently in the late stages of the development phase and approaching the time where we'll be able to test these improvements. If you're interested in testing our improved EMCT certification process, please email me at travis.connors@azdhs.gov. We greatly appreciate feedback and involvement from our stakeholders to ensure a successful implementation that greatly benefits all parties and provides added value to our daily, monthly, and yearly functions. Now turning over to the education resources portion. Our Bureau is excited to announce that we're inching closer to implementing our improved EMS education webpage. The improved webpage will provide an enhanced visual appearance, a reorganization of the information and resources provided in the webpage so that our end users can find the relevant and specific information in a much more efficient manner, and much more. A few aspects of the webpage that we focus heavily on are the continuing education and upcoming course schedule. The continuing education section, which is already live now on our website, provides a much more detailed and comprehensive list of CE courses that are free or low cost, with the goal of providing additional and easy to access resources to improve workforce trends. Additionally, the upcoming course schedule, which is not yet implemented, will now provide the end user with a calendar that displays all upcoming courses, which can be filtered by the type of course an individual is interested in, as well as the specific data needed to enroll, such as the address, contact info, etc. Rather than having our community search through a busy PDF to find a course that fits their need, one will be able to search through an easy-to-use Google Calendar that allows for filters and that is updated on a regular basis. If you have any questions about this update, please contact Cody Curl. Her email address is Cody, CODY, period, CURL, @azdhs.gov. Thank you all and have a great day.
Thank you, Travis. All right, next on the agenda, we wanted to mention that at the November Education Committee meeting, the Education Committee had finalized and approved a training curriculum on COVID-19 trends, medical decision-making capacity, and patient refusal training. This is available on our website. As you can see linked here, there's the presentation in PowerPoint format. We also have a video link as well that agencies can download. We have received some feedback that the YouTube format that is published on our website may not work with your training program software. So if you need us to send it in another format, we certainly can. A big thank you to Dr. Rice from Southern Arizona, who very kindly recorded the video on the training curriculum for the state. Again, this is a really well done curriculum that highlights some of the changes and trends that we have seen statewide and nationally regarding COVID-19 and patient acuity, and some of the effect of that in patient refusals. So thank you to that committee for finalizing that education, and a big thank you for Dr. Rice to record that in the video format for agencies. Next, for our standing committee reports, Sarah Parati has to go work clinically, so I'm going to just jump on the agenda and have her cover a SAMES report first, if the committee is okay. Sarah, are you available?
Yes, thank you, Dr. Bradley. We held our annual meeting on Tuesday, January 18th, at which time we had our annual election. Chief Brandhuber was again nominated and voted as the vice chair. I have reflected all of the pertinent changes to our report that came of the January 18th meeting, so it should be available for everyone's review now. In addition, I just wanted to comment on the fact that we had such a large participation from you all at DHS. We appreciate your participation in our meetings. You know, our January 18th meeting, given it was our annual meeting, it was nice to have all of the involvement, as well as following along with the issues, though many, that we've presented to you. So I just wanted to communicate that from our members. We appreciate it. I don't have anything else. I did submit the report, so if I can answer any questions, I certainly will do.
Thank you, Sarah. We appreciate that. Any questions, or we can move along on the agenda? All right, hearing none, I will go back to the top. Rebecca, for a TEPI report, please.
Good morning. Thank you, Dr. Bradley. TEPI last met on November 16th. We welcomed one new member, Kimberly Larkins, to our group, and we were also given notice of a vacancy. If any of you have an air ambulance premier EMS agency quality improvement officer, we're looking for someone to fill this role on the TEPI committee. Should you know someone who you think might be interested or qualified, you can always give their name and contact information to Shelley Bissell, and she can follow up. Let's see, some of the various reports we had. Again, Dr. Bradley hit on it so well this morning already. I won't reiterate about the Naloxone Leave Behind program, but please take advantage of it as an agency so that you have this to distribute in your communities as needed. The Safe Hearts in Arizona, again, we had the update from Julie regarding the SHARE program. And we're so happy to see that this is being revamped and pushed forward again, encouraging people to get back active in this process in case they slipped away. We also had a report for EMS for Children from Adam Rodriguez. And all of you have probably seen the survey regarding EMS for Children that just came out in the last week. Please take a moment to complete that and return it. It helps the state have a much better picture of what our pediatric capabilities are overall. Annual reports included snapshots of trauma and EMS. Vatsal, as always, does an excellent job with these reports, so I encourage you to take a look at them when you have the opportunity. And then, as Mr. Connors just shared, there was discussion about the EMS portal revamp. I think it's exciting what they're going to be bringing forth for EMS to utilize. Then there were updates from the usual groups, including Trauma Registry, Trauma Program Manager, and the EMS Registry Users Groups. Finally, we did accept nominations and approve a vice chair. However, we're still waiting for someone to step up for that position. We did not have any nominees identified as of the last meeting, so this position will remain on our agenda until we get it filled. Other than that, our next meeting will be March 17th of this year at 9 o'clock. Let's just put location to be announced. And that's my TEPI report. Thank you.
Thank you, Rebecca. Next up, Brian for Education Committee report.
Thank you, and good morning, everyone. Education Committee also met on November 18th. As Dr. Bradley had noted, we approved the COVID-19 trends, decision-making capacity, and patient refusal education. There were also two other education packages that have been on hold since September of about 2018 that Medical Direction Commission had previously approved for supplemental training for EMTs. And we approved a training packet for the STR for epinephrine intramuscular for allergic reactions for the EMTs. That's a nice addition. Been waiting for a long time for the rule package to be able to open up so we could change the scope of practice. Also was approved capnography for EMTs as a supplemental training required skill, and that package also was approved. There was a discussion to form a work group to look at maternal resuscitation and interventions, and there was seeking volunteers to join that work group. And also, we also looked at the table of posted trainings that's on our schedule for every time to see what kind of education may need to be updated that's been posted on the website. And that's my report for Education Committee.
Thank you, Brian. I'll let you keep going for the PMD update as well.
Protocols, medications, and devices also met on November 18th. There was a group that was tasked with looking at drug profiles. These have never existed before for Table 2, which is the agents that are eligible for administration during a hazardous material incident. Those drug profiles will be moving forward to Medical Direction Commission today. There was also two TTGs that were proposed for hydrocarbons and met hemoglobinemia for TTGs. On those, they'll be moving forward to Medical Direction Commission today also. Then there was also approved to update Table 2 which is the agents eligible for administration during a hazardous material incident, to remove activated charcoal, pyridoxine, sterile water, and reorganizing the generic and registered names on that table. That will also be moving forward to Medical Direction Commission today. And that's my report on that.
Thank you, Brian. Next, we will move to the regional EMS council reports. First up is Roy for Ames report.
Thank you, Dr. Bradley. The written report is included in your packet. I don't really have anything to add to that. In an interest of time, I'll let you just peruse that at your leisure, other than to say that we're in the process and are getting good response at this point on the educational survey that the Bureau and the 4 regions have instituted, and we're looking to get better participation by continuing to advertise and providing the link to EMS agencies and personnel.
Thank you very much, Roy. Next up, Vince for names update.
Good morning. Names is going on. We're going to proceed with our 13th annual Arizona Pediatric Symposium. It'll be Monday, February 28th and Tuesday, March 1st. And you can register on the NAMES website. And it's in person with hands-on training at the Little America Hotel and Conference Center. And the symposium will continue to focus on our pediatric care in the pre-hospital and hospital setting. So we will be giving out CEs. We met on November 5th, and not going to go over everything, just the highlights. Just remind our people that NAMES annual memberships dues are initiating for 2022. And in February, we will have elections for 2 officer positions. That's the vice chair and the treasurer. And FMC Trauma, they are still performing Stop the Bleed instructor training programs. And we are donating supplies to give out for those trainings. And just a reminder that area agencies can contact FMC Trauma, and we can help distribute some PPE supplies for donation. And most recently, we gave a huge donation to the Hopi EMS tribe. And I submitted my report as is. Thank you.
Thank you very much, Vince. Next up, Rod for Western Region update.
Hey, good morning. We had our last meeting earlier this month on the 13th in Lake Havasu City. Was fairly chaotic as we had a EMS incident right outside of the building where we're holding the meeting, but we got through it. The next general meeting is May 12th, also in Lake Havasu City. That's our annual meeting. We will elect a president and secretary. We're still working on this year's provider assistance grants. We are also working with the Arizona Center for Rural Health on some Arizona Rural Hospital Flex funds that they had come available for the regions. And we are sponsoring a CISM refresher class February 7th in the Kingman area. And we've been working with Chief Garcia and the other regions on coming up with some ways to combat this current surge. And I really appreciate them stepping out and coming forward for that. And that's all I got.
All right, thank you very much, Rod. Next up, Dr. Woolridge for a PACES update.
Hey, Dr. Bradley, this is Adam. I think I'm going to go ahead and take care of that for Dr. Woolridge. And so PACES, we had a recent vacancy in council members, so we are searching for a new council member. A nurse with pediatric experience is preferred, and I appreciate your contact earlier, Dr. Bradley. We're very close to approving a naloxone training tool that we'll see up on the website very soon. At the last meeting, we compiled and reviewed resources for behavioral health, for the behavioral health work group, and we're also looking for someone there that has a behavioral health background. If anybody knows somebody that would like to help out our PACES subgroup, anybody with a behavioral health background would be lovely. And we also approved the creation of a work group that's going to try and identify training gap topics for EMS personnel. And our next meeting is on March 17th. And that's all I got.
All right, thank you very much, Adam. Next to our discussion and action items, if I can get a motion to discuss, amend, and approve the EMS meeting minutes from September 16, 2021. Just a reminder for the virtual format, if you can please say your name if you make the motion or second the motion.
So moved, Brian.
Thank you, Brian.
Second, Roy.
Thank you, Roy. All right, we'll take a minute to peruse these. Again, these are available virtually in your meeting packets as well as one of the agenda item links. Are there any recommended revisions to the meeting minutes? Hearing none, anyone opposed, please say nay. Hearing none, any abstentions? All those in favor, please say aye.
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 Thank you. Next item on the agenda was a discussion item that Dr. Castro-Marin had requested to be brought to EMS Council. I do not see him on the meeting today, so we will table this item. Just confirming that he is not on the line. All right. Next, we are going to just discuss Public Health Workforce Grant and Regional Needs Assessment. I'm going to turn this over to Chief Garcia.
All right, good morning again. I think that it was touched on by some of our regional council representatives that we have been working, the Bureau with the 4 EMS regional councils to put together a workforce needs and interests assessment. We recognize the continued stress put on a finite number of frontline workers right now. Each region will be promoting the survey that has been developed. And we ask that the statutory committees also encourage participation so we can gain some more insight into statewide and regional workforce needs. We know that it'll take a few minutes, but we ask that everyone please complete this confidential survey. We also want to say thank you to all of our frontline workers for everything that they're doing. That survey is currently open until February. Thank you again to the regions for pushing it out. We will make sure that we make that link available to this group as well.
All right, thank you very much. Next on the agenda, we would like to discuss a best practice from Southern Arizona regarding some coordination between hospitals and EMS. Chief Brandhuber, I'm going to open it up to you, and if there's anyone else from your team that would like to discuss what you've done in Southern Arizona.
Thank you, Dr. Bradley. Good morning to everybody. Real quick, there was a lot of people involved in this, and what we did was basically identified the wall time problem we were having with ambulances being held up in the ERs, and we grouped patients into red, yellow, and green, and to cut down and simplify the turnover at the ERs. There were many people involved in this. Specifically, I want to give credit to Dr. Zakowski, and I know she's on the line, so I'm going to kick this over to her for her efforts in this. Dr. Gaither helped a lot. Chief Brian Stevens from Tucson Fire Department was critical help, as was Jackie Evans of GMR. And also want to thank Chief Garcia and Odette Colburn from ADHS, because they participated in the calls that we had with the hospital CEOs. And before I kick it over to Dr. Zakowski, I think that was the most critical part, was getting to the C-suite at the hospitals, explaining the problem, explaining what we were going to be forced to do. And once we had their attention, we were able to work through the issue pretty quickly. So Dr. Zakowski, do you want to talk about the plan that you basically developed?
Thanks, Tom. So definitely a huge group effort, as Tom mentioned, something that we're incredibly proud of down here. So I am Melissa Zukowski. For those that don't know me, I'm the medical director of the emergency department at Banner Tucson, and work clinically bedside in our pediatric ED. But Tom and Josh had reached out initially to our executive leaders across all the hospitals in Tucson. And then as the medical directors and EMS directors at the hospital level, we were brought in as well and developed really a process by which we are really targeting very, very hard throughout our hospitals to work with our EMS colleagues to make sure that we can get their offload times down. As everyone can imagine, speaking to the choir, you know, those have gone up significantly with what we've all been dealing with over the last 2 years. And so what we developed, and I'm not sure if it's attached at all to what's being projected, but developed basically kind of a stoplight program of green. There's a little bit in the yellow and red, but basically the red being, here are those patients that absolutely, doesn't matter how busy the emergency departments are, these are the list of patients that need to be offloaded immediately, be it STEMI, strokes, laboring patients, etc. And then probably I think what has been the biggest win has really been our green group. And so what we recognize is that with the hospitals being overwhelmed, we have not been able to get those patients direct bedded the way we used to. And so we have been able to really get a very large group of patients into that green zone that we feel comfortable at the hospital level of getting those patients offloaded from our EMS colleagues. A strong handoff between the nursing, be it the charge nurse or triage nurse, via a form. And I think Gail maybe had posted that up off the website. But there's a handoff triage form, and then those patients go to the lobby. So this has been really quite successful so far. Tom is also, and the EMS group has also developed the website where we as the hospitals can go in and see what our offload times are. But I think it's been really incredible so far, just the, the collaborative, recognizing that everybody's on the same team. And it's really made for a lot better relationships, I think, with our EMS colleagues and our hospitals, and vice versa, just to recognize that we are all struggling. As much as we may feel like we don't have a space in the ED at that time for yet another patient, we recognize that our EMS colleagues have got to get back out for that call and how critical that is. And so I just think the relationships and those handoffs have been strengthened significantly. And then also built into that process is really, we tried to make it as tight as we could an escalation process to get to our EMS leaders should we really be having trouble at any of the local hospitals. So kind of boots on the ground, the medical directors and EMS colleagues work together to really develop it. But as Tom said, I think his engagement of the C-suite leaders across Pima County and Tucson were really critical in having them recognize, really what we need to do as the EDs to help support our EMS community. So I can turn it back to you, Tom, for any additional comments. But thank you all for having me today. I really appreciate it. It's been a pleasure working so closely with EMS.
Thank you, Dr. Zukowski. The other part I think was important is, we asked a lot of the hospitals and kind of in return, what we also did was make sure that we're educating our providers and crews to communicate to the patients that, going to the ER at this time is not going to get them ahead in the line, and that they might be under this plan, they will be going to the lobby. And so not to discourage people from calling 911, but to educate them. And the other important part too was to stress to the crews that freestanding ERs or the micro ERs sometimes are not the best place to take a patient. We should take them to a facility, even if it might be a longer offload time, because that patient at the freestanding ER might have to be transported to a different emergency room. So it has been a collaborative effort. We are collecting the data. Dr. Bradley sent the website address out. Thank you, Dr. Bradley. And that's been a key part too, that we're showing the numbers. And in the short 2 weeks that we captured data after we started this, we did see a decline in maximum out of serve wall time and the 90th percentile wall time. We will refresh for the month of January and have that data up in February. And, we're open to questions, but again, I think the biggest thing is to collaborate and to work with the hospitals to get the buy-in.
Thank you, Chief Randhuber and Dr. Zakowski, for your discussion on this. It's really been impressive to be a part of those meetings and see what started at the first meeting. I think you probably would agree was a little contentious, but really after a series of meetings, seeing the collaboration that occurred and then the outcome, really a best practice. And we want to try to highlight some of these issues. We recognize that currently within all of Arizona, as well as nationally, hospitals are in a state of surge, combined with the fact that we have very, staffing shortages as well. And so just looking at these processes, again, in the chat, there is a copy of the website if you want to peruse that also has the protocol with their directed triage type process. Interestingly, last week at the National Association of EMS Physicians, there was an agency that presented on some of their efforts. And one of the efforts they discussed was really kind of making an official, formal directed triage process and how effective that was for their agency as well. Again, establishing set guidelines so it wasn't up to the discretion of the individual paramedic, EMT, or nurse, but really a set standard that everyone felt comfortable with, and letting the hospital know before the patient arrived so that the conversation was kind of already made. So again, kudos to your team for such great efforts on this, and we wanted to really highlight that to EMS Council. I wanted to open up if there's any questions for them. Please feel free to speak up right now. All right, hearing no questions. Oh,
sorry,
go ahead, Matt.
I just had a question. I'm curious how do you get past the ED when they say, we just have no beds, we have no nurses, but the patient is not appropriate for triage? Like, that seems to be the hurdle that we're stuck at least locally up here. How have you gotten past that?
So on the it's called the Offload plan. It's that would be probably a patient in the yellow, and we have goal times. The goal time is to that patient be offloaded in 15 minutes, not to exceed 30 minutes. And then on the second part of the plan is a offload escalation plan, and I'm not aware that it's had to be used yet, but it's there so that supervisors from the organization directly interface with the emergency director at the hospital or charge nurse to fix that. And then bottom line is we have, if it can't be done after 60 minutes, the providers have stated that they will leave the patient to return back to service. Again, that hasn't been done, but I think it was critical to put in some final timelines so that people would work not to exceed those. But I'm probably not answering your question very well. I'm sorry. But the yellow patients, if you look at the plan, are the difficult ones. The green ones are pretty easy. The red ones are very self-evident and they get worked on right away. But it's the patients in the yellow that do cause some of the delay. But following the plan, and that's the other important thing, is all the hospitals and all the providers are following this plan. So regardless of what facility they go to, it's the same expectation and the same protocol that is being followed. So I think I just rambled on and didn't answer your question, so sorry.
No, thank you. For the, just I guess a follow-up, for the after 60 minutes, when there's the option for to just leave the patient and let the unit return to service, what does that actually look like? I know you said you haven't done it yet, but I'm guessing you guys have at least game planned it a little bit.
Mike, do you want me to speak to
Tom,
that?
I'll chime in if you want.
Yep.
It's Chief Stevens. Good morning, everyone and members. I was part of that team, that BEMSTS team that worked on this regional issue here in Tucson. It was a good effort. I'd like Dr. Zakowski and Tom Bremhuber said, the leadership. When we started looking at it individually, it was going to be bigger than one agency trying to tackle it. And I think the group getting together, pulling all the resources together and getting everybody sitting at the table talking about it was a huge success. So being new to the EMS division for Tucson Fire, I was proud to be on that group and work with those individuals to see how collectively we could work and come to a solution. As far as down here in Tucson, getting ALS crews out of the ERs, there's been some times there where, you know, they've exceeded times, and we work through it with using our management teams, our EMS captains. The few times that we've had to exceed or get close to that 1 hour of time, it's mainly either the management team, a chief or an EC captain, following up at the hospital and just trying to work with the charge nurse and the crews there, trying to understand what's going on. Our crews aren't hard set, you know, like, you know, 45 minutes and that's it, I'm out of here. And so we try to work together. We understand the situation we're all in, and depending on what's going on in the city and the resources we have available, we can slide those times a little bit. The one incident that I had an individual call me was well over an hour, try to work through what happened, what we could do to facilitate an offload. And it just basically came down to finding some space and filling out a transfer form and leaving the patient with the charge nurse, with a collaborative effort between the management team and the hospital. So it did work. I don't know if that answered your question, sir.
Yeah, to the charge nurse, I guess that was kind of what I was wondering, because I'm imagining someone had to take responsibility for the patient. So that does. Thank you very much. I appreciate it.
Thank you. I see Dr. Godzenker has a hand up next, and then Vince after that.
Hey, this is Eve, Dr. Godzenker. First off, this is really exciting. I really like kind of what you guys were doing here, and it's speaking actually with some of the battalion chiefs here right now about it as well. Did you find that you needed to get buy-in from the hospital, like CMO, CFO, or not CFO, sorry, CMO, just because of that option of that 60 minutes we're going to leave situation? I know you haven't come across it, but did you kind of cross that bridge initially as well?
Dr. Zakowski, do you want to speak on that, or do you want?
Yeah, I can take that one. So yeah, absolutely. It was kind of a multi-tier approach. So the initial meetings really had a lot of attendance by our C-suites at all the different hospitals. Usually the CEO and CMOs were on the call in most cases, or their representative, and definitely needed to get them engaged. And I think that, you know, Tom did a really great job of bringing it to them that, you know, we really have to figure out a solution, because the way that we were moving in a completely wrong direction could not continue. And so that really helped. And then I think what happened then is that we actually took a breakout group of those of us that actually work in the emergency departments, the medical directors, with our EMS colleagues, and really kind of worked through the process. And I think the C-suites kind of recognize that, you know, we kind of all recognize what's happening in the emergency departments and then on those offload offload times. And so when we brought this plan back to them, I think it was actually very well received. You know, I agree. I think that first meeting was a little bit rough, but I think as we got more to the people that actually do the work, that's when we really started to make a lot of headway. And our C-suites from there have been very receptive. And then just to answer the question, as we're kind of getting to those, you know, timeline cutoffs, you know, I think for the hospital, it's been good to have us all on the same page, because we definitely recognize those patients that, number one, are in the green. And although those are a lot of patients that we would have never pre-pandemic ever wanted to put out into a lobby, and we have lobby patients that wait, you know, on oxygen, et cetera, lots of things that we had to get very comfortable with fast, recognizing that this is the situation we're in. But in particular with those yellow patients, I think we just have a much more proactive kind of mindset when we know those types of patients are coming our way, and that we need to figure out a way to rearrange patients and get a bed open. And then we've also had scenarios at our institution where we have actually, you know, had a trauma patient on a gurney up in our front end, you know, by the staff and the physician that works out there. So we've had to get very creative with space sometimes. But yeah, I think C-suites across town have actually been quite engaged and really kind of understood once we took this plan back to them. Hopefully that helps. Thank you.
Thank you. And then I think I see Vince, you're up next with a question as well.
It's more of an ask for Tom. First of all, this is a pretty solid plan. I think that, you know, we have some elements of this that we definitely could incorporate into our system up here. Hey, Tom, can you email that to me? We're one of the agencies that has such a strong firewall, I can't open the Google Docs.
Yes, sir. As soon as out of this meeting, I'll get it over to you.
I appreciate that. Thank you for the work.
Thank you. I did share in the chat a link to their website, and then also currently share on the screen This is the offload protocol that they set in place that is linked in that website as well. Any further questions? All right. Next. Oh, yes, go ahead.
Dr. Bradley, could you reshare that link? I had a loss of connection there for a second, and I no longer have that available on my screen. So if you could reshare that,
Yes.
it would get approved.
I will do that right now in the chat.
Thank you.
All right. Next up, we just wanted to discuss crisis standards of care and staffing. We recognize that there was some questions that we have fielded regarding who is eligible for essentially crisis standards of care staffing. A reminder that EMS providers do fall under the healthcare worker category. So if you look at AZDHS's return from isolation and quarantine guidance, there is a section that links for healthcare workers to the CDC guidance. The CDC guidance then expands for healthcare workers based on your staffing levels. So are you in conventional, contingency, or crisis levels of staffing? And so we have fielded quite a few questions, but wanted to remind everyone that there is the option if your agency is in a crisis standards from a staffing perspective, that you can have the shortened return to work for individuals who are asymptomatic or with mild symptoms. So again, just a reminder, if you have any questions about that, there is the link to that document on the DHS website, and it does also then link to the CDC guidance as well. Any questions regarding that? All right, next for discussion item, as Chief Garcia had mentioned previously, we had quite a bit of back and forth on scope of practice, which had gone through the exempt rulemaking process and was updated. One of the items that has come forward once that was finalized, I think probably the day after it was finalized and posted, were two specific requests. And many of these came from the hospitals who are utilizing both EMTs and paramedics to provide quite a bit of care, including ultrasound-guided IVs and venous blood sampling. So we'll tackle kind of one at a time, but the first one being ultrasound-guided IV. This is going to go as an action item on MDC today for discussion. This is something which would be a STR because, again, it's not part of the original training, but many hospital systems have been utilizing paramedics to perform ultrasound-guided IVs. This is a procedure which is very beneficial for patients who are a difficult stick, and it is somewhat time and labor intensive. And so this has been a request from multiple hospital systems that if they adequately train their paramedics who are employed in the hospital and the administrative medical direction approves it at that facility, can they perform that? So we wanted to make sure that we brought that item back to this committee for discussion. So I just wanted to give that background and then open it up for further discussion.
Hi, it's Brian.
Yes, go ahead, Brian.
Just hopefully one quick question. Is there a specific reason that this didn't go back through the working committee before it came forward to basically Medical Direction Commission is going to have the final say, but it just seems like this should have gone to PMD to look at and move forward.
Yes, thank you, Brian. Really, this was a matter of timing and the kind of frantic requests we are getting from hospitals with just the absolute workforce shortage and trying to find any way to kind of help increase what's available for patient care. So that's really the only reason that it did not go through the process that we've done previously. Any other questions, concerns, or comments that we can move forward to MDC?
Hi, it's Brian. Sorry. I think I do have one more question. Is it the thought that the venous blood sampling is the ability to be able to use vacutainers and things like that to draw blood, because in the paramedic scope, there's a IV access already that's approved that would resolve that issue. I think you can start an IV, you can draw blood through the venous access. This was, I think, designed more at the paramedic level for things like iStats and being able to interpret values, use iStats and interpret values and things like that, rather than just a simple task of accessing a peripheral vein to obtain a blood sample.
I apologize, Brian, that's the next item for discussion on the agenda. I just want to make sure we close out the ultrasound guided, and then we can tackle that next question. I see Dr. Godzenker has his hand up for a question. Dr. Godzenker, was your question in regards to the ultrasound guided IV?
It's on that line, but maybe a bit of a tangent. So that's the long and short being, if we're talking about ultrasound guided IVs, if we can also make it a special training just for medics to be able to use ultrasound in general, such as for FAST or EFAST.
Thank you. I think at this point, the request and the action item would be specific to ultrasound guided IV for MDC to consider. So is there any other discussion regarding ultrasound guided IV, or would you like to move to the next section? All right, we will go ahead. All right, so for the next action item or discussion item, Brian, in regards to your question, there was quite a bit of discussion. I think many of us, when we did the scope of practice initially, in my mind, we kind of pictured that when an individual is starting an IV, they are often drawing blood because that's what is done in the hospital setting. However, in the pre-hospital setting, predominantly the for EMS providers are simply starting an IV. They're not doing a blood draw with that. And so there was a feel that the scope of practice currently does not allow an EMT to draw blood when they start an IV because it's not explicitly listed as a STR on the scope of practice. So while we did add peripheral IV insertion to the scope of practice for EMTs, that was one of the additions that was made. The request was to make sure that we had full coverage for EMTs, especially working in the hospital setting, that if they're drawing or starting an IV, that they can draw blood as part of that. So this is venous blood sampling, meaning drawing blood. It's nothing to do with diagnostic testing. Does that answer your question?
But I think you're putting it on the same line that already exists for the other scopes, don't you? Isn't it? I'm just trying to make sure that, because my understanding of the intent was that is a little bit different than what you're describing, to try to make it as an STR to just simply be able to access a vein to draw blood.
I don't see another place on the scope of practice where we have venous blood draw anywhere else, other than this line. It's highlighted with the red STR edition.
Well, but in IV initiation maintenance fluids on item 4, it's intravenous access, and it doesn't say anything else. The next line has intravenous initiation. So you have one line where you can access a vein and another one where you can initiate peripheral IVs, which seems to me to cover it. And they're already both listed as STRs, but I guess that just comes down to a matter of what people's interpretation of stuff are, but that's different than what my understanding of that venous blood sampling line originally was designed for, coming out of the national scope of practice.
So the request from stakeholders across the state was to make it very clear with venous blood sampling, since that was called out separately, that is something that that EMTs as a STR can draw labs to perform that skill set as a STR.
This is Garth Kamer. I totally understand the ask that the Bureau was presented with, and I think as pictured, this addresses the concerns of those that directed queries to the Bureau. And I'm in favor of this as written. The question that Dr. Godsanger brought up is another topic for another day, but that's worth approaching as well. Thank you.
Thank you, Dr. James. Any further discussion on these two items? Matt, go ahead.
Is the intention for this, the ultrasound guided IV, to only be in hospital? Like, will there be a asterisk or something that indicates that, or because it's on this table, it could be done pre-hospitally as well?
That is a good discussion. So it would have to be very specifically ultrasound guided IV. Once it's on the scope of practice, it would not be limited. I do realize that your entity does have the ultrasound machine. So certainly the ultrasound guided IV, if it's approved and added to scope of practice as a STR, once it's added, we don't have anything that is hospital specific. But that is really kind of the setting that this will most likely occur.
Okay, thank you.
Does that answer your question, Matt?
It does. Thank you.
Thank you. Any further questions? All right, any agenda items for consideration for the next meeting, please email them to either Shelley or myself. Call to the public. All right, hearing none. Summary of current events. Those are hyperlinked in your agenda packet as well. Our next meeting will be May 19th, 2022. Again, whether it will be hybrid or completely virtual will be to be determined. And we will go ahead and adjourn the meeting at 11:43. Thank you very much, everyone.
Thank you.
Thank you.
Thank you. Bye, Rebecca.